First, I would like to introduce Dr. Ronnie Ho. He's going to give the first talk on the histopathological features of Pompe's disease. So Dr. Ronnie Ho is now a consultant pathologist, currently at Gleneagles Hospital, Hong Kong, and previously also worked in Queen Mary Hospital, the University of Hong Kong. He obtained his medical degree from the University of Hong Kong in 2007 and underwent specialty training in anatomical pathology in Queen Mary Hospital. He furthered his subspecialty training in neuropathology and neuromuscular disease in the University of California, San Francisco, and also the Dilbervus Neuromuscular Center at Great Ormond Street Hospital in London. He was then the neuropathologist in charge in Queen Mary Hospital, being responsible for most, if not all, the muscles and nerve biopsies. In addition, he also takes care of those neurosurgical specimens. During his time in Queen Mary Hospital, I also worked closely with him. He is really excellent. He has introduced and enhanced a lot of diagnostic tests and specialized staining for the muscle biopsies as well as the brain tumors. He has been working very closely not only with pediatric neurologists like myself and also with the adult neurologists as well as the scientists. And together, with his work, actually, he contributed to various of the related research paper. So without undue delay, I give the time to Dr. Ho. Thank you.
Thank you very much, Sophia, for your kind introduction and the opportunity to share with you a review of histopathological features of Pompe disease. So some disclaimer from Sanovi and myself. So Pompe disease is a heterogeneous disease. It presents as a clinical continuum of clinical severity and age of onset. The most severe form is, of course, the infantile form, and it also includes late onset, including adult forms, which is less devastating with less significant cardiac involvement. And the pathological features also differs between these forms, which I will explain in detail later. And as the name of the disease, Pompe disease also goes by type 2 GSD, glycogen storage disease. So it would be intuitive and reasonable to expect glycogen accumulation as central to the pathological change in the disease. And indeed, excessive glycogen accumulation is present in a generalized manner, especially in infantile biopsy cases. And glycogen can be actually demonstrated, including but not limited to skeletal muscle, heart, central nervous system, etc. So actually, while I begin to prepare for this talk, I found that it is more interesting and actually very important to understand the pathophysiology rather than giving a very pure descriptive approach in explaining the skeletal muscle pathology. So when talking about glycogen accumulation, it would be useful to refer to the study by Thurber and his colleagues, which semi-quantified the pre- and post-enzyme replacement changes in infantile onset Pompe disease. And they divide the severity of skeletal muscle pathology into 5 stages. And in this model, which explains the glycogen accumulation, it is actually quite inspiring because it describes the light microscopic changes when one sees a muscle biopsy. So because of the deficiency of the lysosomal enzyme exit alpha-glucosidase, failure to digest the lysosomal glycogen, so you would expect the lysosomes in skeletal muscle fibers to be progressively enlarged. So on your right, stage 1 is, of course, the least severe stage. So most of the glycogen still is present in the lysosome. So as this stage, clinically, the myopathy is mild. But with increasing lysosomal glycogen storage, which eventually leads to rupture because they are basically engorged with glycogen. So eventually, the glycogen particles would be released into the cytoplasm. And not only is glycogen released in the cytoplasm, actually other lytic enzymes in this lysosome would also be released. So this is thought to result in damage to the muscle fibrils. And so eventually the contractile elements would be destroyed, and also there will be water influx into the muscle, leading to swelling of the muscle fibers as seen under light microscopy. So with this increasing severity of glycogen accumulation, as you can see on the right, eventually would progress to complete loss of the contractile function of the muscle fibers. So going back, so actually type 2 glycogen disease is the only form of glycogen storage disease that shows a lysosomal abnormality, because this enzyme lies in the lysosome. So amongst all the glycogenoses, lysosomal storage abnormality is the only Pompe disease is the only disease that shows the lysosomal engorgement. So I want to remind you that the study done by Thurberg is actually based on electron microscopy. But on light microscopy, one can still appreciate to some degree the pathological changes. So under light microscopy, you will see a marked vacuolar appearance, or some would describe it as a lace-like appearance of the muscle fibers, as seen on your left. So this is a periodic acid shift stain, which is famous for staining up glycogen particles. And if it is positive for PAS stain and digested by the enzyme diastase, then we would be able to confirm that the deposit is glycogen. But note that in routine biopsies, which are usually frozen, the glycogen can be lost in tissue processing. So besides doing a routine frozen section, it would be very useful to do a PAS staining of the epoxy resin sections. So epoxy resin sections are usually done, it can be examined under light microscopy, or also for preparation of ultra-thin section for electron microscopy. So as already mentioned by Dr. Nishino, so with the glutaraldehyde fixation, the glycogen will be preserved, and the quality of the PAS staining, as I will show later, would be much better. But of course, this technique is not routinely done for all muscle biopsies submitted to anatomical pathology lab. So in theory, if you do just a frozen section of the muscle, you may or may not be able to demonstrate that the vacuoles contain glycogen. So just for your comparison, the PAS stain in the center of the center image is the normal pattern of staining. It will stain up the intermyofibrillary network, and in normal, at least a non-Pompe disease control is shown here with the H&E staining. So you do not see the vacuoles. So in this study, which also again try to quantify the pre and post treatment changes in infantile Pompe disease. So I'm showing you this figure because it shows nicely the comparison between a mild case and a severe case. So in the so-called mild case, the extent of vacuolar change or glycogen deposition, of course, would be much less than the severe case. But then some fibers, they do have abundant glycogen accumulation amounting to deposition of such metachromatic or amorphous material. And in the severe case, you can see that basically the contractile elements, which will stain reddish pink by H&E, are basically all gone. And the same applies for the PAS. So this is similar to the previous image I showed you. And the bottom row shows the quality of the PAS staining if you do it on the resin section. So you can see there's a very nice contrast with the background toluidine blue staining, and much of the glycogen particles, they still stain purplish with this PAS and much preserved on this resin section. So the theory of glycogen accumulation has long been thought to be the central pathology of Pompe disease. But actually, with time, it was found that it's not the case, especially in late onset, including adult cases. Because firstly, it's not always demonstrable in muscle biopsies, especially in late onset and adult patients. And with the availability of the enzyme replacement treatment, this notion is challenged because if glycogen accumulation were the only mechanism, then we would expect a better response to enzyme replacement, especially in skeletal muscle. Because it's known that enzyme replacement, it improves the cardiac function, but the skeletal muscle response is not as good as one would hope. And lastly, actually something abnormal was described as early as in the 70s, but it was somewhat forgotten until in late studies in 2008. So, therefore this glycogen accumulation is an oversimplified model of the disease. And this extra abnormal pathology is because of the role of autophagy in Pompe disease. So autophagy, it literally means self-digestion. So you may have heard that this is a very important mechanism by which the cell get rid of the worn out organelles. But actually it is also very important in catabolizing macromolecules so that the cell can derive glucose, amino acids, and other molecules for normal cellular function. So in this autophagy model, the theory is that if there is a lack of the lysosomal enzyme, then the cell will be cannot digest glycogen. So it will induce a local sort of starvation response that will stimulate further autophagy. And in addition, in Pompe disease, it is found that the autophagy is actually profoundly disturbed. So there's a defective fusion of the lysosome and autophagosomes. And autophagosomes is formed by eating up of the cytoplasm by double membrane vesicles, and the normal mechanism would be that it fuses with lysosomes and got digested. So this process is disturbed in Pompe disease. So with the stimulation and then the defective fusion, with time there will be a phenomenon called autophagy buildup. So the end result is that the skeletal muscle will accumulate lots of undigested material, literally garbage. So these garbage may be potentially toxic to the skeletal muscle as well. So on your left, you have a electron microscopy picture showing you the typical appearance of autophagic debris in a skeletal muscle fiber. So in short, Pompe disease actually should be viewed as an autophagic myopathy, not only a simple glycogen storage disease. And the impaired autophagy not only affects the cellular function, it also actually affects the mitochondria as well. Because worn out or defective mitochondria, they also needs to be cleared by a process called mitophagy. And if there is an impaired mitophagy, that will cause lots of mitochondrial abnormalities that's demonstrated in some studies. And there would be loss of the membrane potential, overload of calcium in the mitochondria, and increase in reactive oxygen species. So when you hear about reactive oxygen species, you would expect these ROS to damage the fibers. And there is also accelerated deposition of lipofuscin. So lipofuscin is actually a so-called aging pigment. It is a undegradable, complex cross-link of protein, lipids, metal, carbohydrates that would deposit in any cell that has been aged and has suffered any oxidative damage. So actually, these lipofuscin, together with the glycogen-laden lysosome, lakes of cytoplasmic glycogen that leaks from the lysosomes, together with the autophagic debris, they will form large clusters of non-contractile material. So eventually, this will affect the contractility of the muscle fiber and leads to muscle damage. And actually, the deposition of lipofuscin is thought to form a vicious cycle because it further reduces the lysosomal degradative activity and also the autophagic turnover. So on your right, this is an electron microscopy of a muscle fiber with some swollen mitochondria. This is taken from the human muscle biopsy. And on the this is the single fiber teased from an infantile onset Pompe disease sample that shows lots of autofluorescent pigment in the center of the muscle fiber, that is lipofuscin. So I've talked about the two main disease mechanisms. So actually, a study done by Dr. Rabin has nicely demonstrated that there is a difference in the predominance of these processes between infant and adults with Pompe disease. So as explained previously, in infantile onset Pompe disease, you would expect lots of lysosomal accumulation of glycogen. So if you do an immunofluorescence staining for LAMP, which is lysosomal associated membrane protein 2, which is specific for this lysosome, you would see that there are lots of lysosomes everywhere throughout the width of the fiber. And there are relatively few green-stained autophagosomes in an infantile case. And the dashed line shows a fiber that has lost its contractile elements. And at the other end, at the late onset or adult cases, interestingly, there are lots of LC3 positive, which is a specific marker for autophagosomes. So you can see that they are deposited. In contrast to the lysosomes, they are mainly concentrated in the core of the muscle fibers. And of course, there would still be some large engorged lysosomes that are stained up by LAMP2, but compared to infantile cases, they are less impressive. So these are some of the data that presented in the study. So these lysosomes in the infantile cases, they can reach in size up to 15 micron, while in adult cases, there are relatively little lysosomal expansion. But instead, the prominent autophagic buildup predominates in adult cases. But as mentioned, not only Pompe disease is a continuum in clinical phenotype, actually the pathology is also a continuum. So in this study, they found that for infants that are put on enzyme replacement, while some fibers they are able to have decreased in glycogen accumulation, they also found gradual autophagic buildup in some fibers, even in infants treated with enzyme replacement. So these very nice fluorescent images that I show you, they require very specialized technique. These T cell single fibers and subject them to high resolution microscopy. So as expected, you would not expect this to be available in a routine lab in Hong Kong. So, but still we can based on this pathophysiological models, we can still expect some abnormalities to be seen in light microscopy. So these are some of the more characteristic findings in late onset cases. So we talk about the value of muscle biopsy in late onset and adult cases because these cases are more difficult to diagnose. This is because different muscle groups and even fibers within the same muscle can show different pathology. So the number of vacuoles can be extensive or very difficult to find. So basically a normal or near normal biopsy does not rule out Pompe disease. And actually the biopsy may have been taken from a so-called wrong muscle. And because of the relative infrequent presence of the lysosomal the glycogen, so if you do a PAS stain, it will become less sensitive. But on the other hand, because of the, in general, the increased lysosomal activity, we can make use of the lysosomal enzyme called acid phosphatase, and also we can also do an immunohistochemical staining for lysosomal protein like lysosomal associated membrane protein 2 or LAMP2. So these markers will be very helpful when one suspects Pompe disease or wants to rule out Pompe disease in a muscle biopsy. Also, with the availability of electron microscopy, one may also detect autophagic vacuoles, lipofuscin, and even mitochondrial abnormalities, although they are less specific. So this figure shows the spectrum of pathological changes in late onset and adult cases. So the top two pictures will show, the almost or near normal appearance on H&E. So it will be extremely difficult to find vacuoles. At most, some mild variation in fiber size, but vacuoles, they are very difficult to see. So on the bottom left picture, you can see occasional vacuoles in some fibers, but still they are not very extensive. And sometimes this may be misinterpreted as artifacts, ice crystal artifacts, for example, especially if the sample has been suboptimally preserved. The bottom right picture shows a more classical appearance with lots of vacuolar change in the biopsy. And this is, on the right, you have the acid phosphatase staining, which shows markedly increased activity in the muscle fibers. And for the glycogen, one can still see membrane brown or intralysosomal glycogen, even in adult or late onset cases. And on the right, you can see lots of glycogen that has escaped into the extra lysosomal space or the cytoplasm. And in several studies, it is found that mitochondrial abnormalities could also be identified, including swelling or even paracrystalline inclusions. So note that these inclusions, they are entirely non-specific. They can be found in many other not unrelated muscle diseases. But this is an interesting observation to make and help validate the mitology problem in the previous slide. And what about lipofuscin? So this is the same figure that Dr. Nishino showed previously. So in this paper, Dr. Nishino and his colleague have shown that the acid phosphatase globular inclusions, they are a valuable clue for diagnosis of Pompe disease, especially when one does not see a lot of vacuoles in the fibers. So in the subsequent study, it is found that these globular inclusions, they are lipofuscin. So they stain for for example, Sudan black, oil red oil that are lipid markers. And also they are found to be autofluorescent, as shown here on the right, that they are autofluorescent. So it is typical of lipofuscin pigment. So again, these images are taken on single fibers with confocal microscopy. So in a routine pathology lab, I would say, therefore, the acid phosphatase would be extremely useful in demonstrating or inferring the presence of lipofuscin. Because the confocal microscopy or even immunofluorescence staining might not be readily available in all pathology labs. So lastly, I would like to bring your attention to a relatively recent study that explored the pathology outside the muscle fibers. So in this study, they found that in several infantile onset Pompe disease muscle biopsies, there are changes in the endomysium. So the endomysium is the interstitial space outside the sarcolemma of a muscle fiber. So this schematic diagram shows that the endomysium typically contains capillaries, the basement membrane of the capillaries, the muscle fibers, collagen, etc. But in Pompe disease, because of the excessive glycogen accumulation, so there will be expansion of the endomysium due to some extruded lysosomal material, glycogen, cellular debris, because of exocytosis or fibrolysis. So also there would be sometimes because of the changes in the muscle, pathological changes in the muscle fibers, usually they may show reduplication of their basal lamina and also of the capillaries. And also they observed that there is hypertrophy or even degeneration of the endothelial cells in the capillaries, leading to narrowing of the vascular lumen. So in this study, they believe that these changes, they pose a physical obstacles to the delivery of infused enzyme replacement therapy because there's an increased distance between the capillaries and the muscle fibers. So this is another way to look at pathology in Pompe disease. So my immediate question is whether these changes could be seen under light microscopy. And in their study, indeed, they are able to demonstrate by Gomorrhea trichome, which typically they stain up the collagen of the endomysium. So they are able, to highlight areas of thickening of the endomysium. But personally, I think it really depends on the quality of the section, the staining quality, and even if present, they might just be thought to be, something very non-specific, not of diagnostic value in Pompe disease. But this is certainly some interesting observations to make. So in summary, I think understanding the pathophysiology of Pompe disease is very important in explaining the histopathological changes and vice versa, because by observing some histological changes like the endomysial or capillary changes, one may gain insight into the pathophysiology and also inform about some implications on treatment. And because of the availability of alternative or other non-invasive diagnostic tests like the dry blood spot test and radiology, the classical picture of Pompe disease in muscle biopsies is rarely seen in clinical practice, unfortunately. And also, vacuolar change can be very subtle, and PAS stain, especially if done only on frozen section, has limited sensitivity. But because, as discussed, Pompe disease is an autophagic myopathy, so if you do lysosomal markers, that would be extremely helpful. In my opinion, although muscle biopsy has a limited clinical value in routine diagnosis nowadays, but I think it does offers a very important insight into the pathophysiology and possibly inform treatment of the disease. So this is the end of my talk. Happy to take any questions. Thank you.
Thank you very much, Dr. Ho, for the excellent review of the histopathological features and also telling us how to think back using the muscle biopsy and the pathological finding, actually have a much better understanding of the underlying mechanism and the diseased process that is ongoing. Is there any question from the floor? Can I just ask one straightforward question? You show that the lipofuscin nicely is actually is the inclusion that is being also explained by Dr. Nishino, Professor Nishino's, that is more common in the adult, the late onset Pompe disease. So what is actually this lipofuscin?
So I think lipofuscin itself is not specific for Pompe disease because, as mentioned, is an aging pigment. It can be observed normally in the heart muscle, in liver, even in the GI tract, etc. So it's rather it's an phenomenon that you observe in Pompe disease that will aid your diagnosis because it reflects the underlying mechanism that the defective autophagy leads to mitochondrial abnormality and hence the creation of lots of oxidative species in the muscle. So it's a sign of oxidative damage to the muscle fibers. Yes.
Thank you very much. You really answered my question. Thanks so much, Dr. Ho.
Thank you. Thank you.
Hello, Ronnie, can I ask a question? So do you think that staining of the S-alpha glucosidase is important or necessary for Pompe disease because the disease has deficiency in this enzyme?
I think I read about doing the enzyme assay on muscle samples. I don't think I come across a lot of papers on staining for the enzyme. But personally, I think it will be very difficult to interpret because there are various levels of the enzyme deficiency. So it will be difficult to gauge the staining intensity, when to say it is deficient, when to say it's, even if you do a staining on a clinically supposed to be normal muscle biopsy, I think you would need lots and lots of normal control to do that. So I don't think it's a good way to diagnose this disease, and therefore probably it's not really explored that much in the literature.
Thank you very much, Dr. Ho.
Thank you.